Okay, now the topic external cephalic version. So we are having a scenario that define external cephalic version and what are the indications, contraindications and complications of external cephalic version. So we are having a definition that it is a maneuver performed at 36 weeks turning the fetus from breech to cephalic position. It is performed in breech presentation at 36 weeks. If complicated, then wait till 37 completed weeks. Okay, so it is a maneuver which is performed at 36 weeks and turning the fetus from breech to cephalic position. It is performed in breech presentation at 36 weeks and if complicated, then wait till 37 completed weeks. Now, the indications for external cephalic version are breech presentation and transverse line. The contraindication for external cephalic version are fetal abnormality, previous history of the C-section, placenta previa, oligohydramnios, polyhydramnios, multiple pregnancies, myomectomy, scar on uterus, fibroid, and APH. If the baby weight is greater than 4 kg, then there is bad obstetric history, and this is also a relative contraindication. Now, the risk factors are premature rupture of membrane, the preterm labor, the placental abruption, the cord accident, the fetal bradycardia, the fetal death, and the transplacental HG. The predictors of successful external cephalic version. Okay, the predictors for successful external cephalic version is maternal abdominal wall should be thin and relaxed, sufficient amount of liquor should be there, breech is not engaged in pelvis, and no uterine anomaly should be there. Okay, now the procedure is that admit the patient, then take the consent, then exclude the risk factors or contraindications, then nil by mouth and nothing per oral, then empty the bladder, then woman should lie flat with left lateral position, intravenous tocolytics are given. Ultrasound gel is applied to the abdomen and obstetrician applies gentle pressure to flex the head and bring it down maternal pelvis while the other hand manipulates this upward in the direction of forward pole. It lasts 10 minutes. If fail, do not repeat. Administer NTD if mother is Rh negative and do CTG. Okay. So we have discussed the external cephalic version, the scenario for it, then what is the definition of ECV, then what are the indications for external cephalic version, and what are the contraindications, and what are the risk factors, then what are the predictors of successful ECN, and what is the procedure, and then now we will discuss the vaginal breech delivery. Okay, so in vaginal breech delivery, we are having a criteria that presentation should be extended breech or flexed breech. Now, the estimated fetal weight is less than 3.5 kg. There should be no feto-pelvic disproportion, and there should be no evidence of hyperextension of the head or fetal abnormalities. The contraindications of vaginal breech delivery are footling breech, weight greater than 3,500 gram, feto-pelvic disproportion, decreased amount of the liquor, and hyperextension of the head or fetal abnormalities. The management option for breech delivery, vaginal breech delivery, is the monitoring of the fetal well-being and progression of the labor. The epidural analgesia prevents pushing before dilatation. Fetal blood sampling from the buttocks provides information about acid-base status. There should be an operator experience in delivery of the breech. And the procedure, patient is placed in the lithotomy position and the catheterization of the bladder is done. Then local anesthesia is infiltrated in the perineum for episiotomy. And confirm the position and station of the fetus. Make sure os is fully dilated. The buttocks lie in anterior-posterior diameter and anterior buttock is delivered and anus is visible. Episiotomy can be done. First deliver the lungs, that is complete flexed and deliver spontaneously. Then extended using finger, flex the leg at knee and extend at hip. That is Penard's maneuver. This method is known as Penard maneuvers. This is important for MCQs. After delivery of the lower body, shoulders are delivered. Baby lies in the transverse diameter of the pelvic mid cavity. The baby will turn anterior posterior position. Finger gently placed above the shoulder and arm delivered. As posterior arm reaches pelvic floor, rotate anteriorly and deliver. Head is delivered by Morrissey smelly weight maneuver. First deliver the downward and then the upward movement. Cover the baby. Back transverse position. Place fingers on maxilla, 2 fingers on shoulder, and gentle traction and head is delivered. Now the complications. We are having the fetal complications and the maternal complications. The fetal complications are trauma, asphyxia, brachial plexus damage, intracranial hemorrhage. The maternal complications are PPH, infections due to irregular tears, and trauma due to manipulative procedures. Okay, so we have discussed the external cephalic version. Then we have discussed the vaginal breech delivery. We have discussed the criteria that the presentation should be extended breech or flexed breech. Then we discussed the contraindications, which is footling breech. Then we discussed the management options for vaginal breech presentation. Then we discussed the procedure, that local anesthesia is given. And then we discussed the method and then the complications which. Okay, now the topic induction of labor. So we are having the definition that it is the planned initiation of the labor prior to its spontaneous onset, and the incidence of induction of labor is 15 to 25% of the all pregnancies. Now the indications for the induction of labor are obstructed indication and medical indications. The obstructed indications are post-death pregnancy that is greater than 12 days beyond the EDD, and the medical indications are severe hypertension, uncontrolled diabetes mellitus, malignancies, and renal diseases. The obstructed indications are fetal growth restrictions and placental insufficiencies, the unexplained APH, the preeclampsia that is high blood pressure in the pregnancy, and the fetal distress. Now the contraindications are, these are the mother, the fetal, and the absolute contraindications and the relative contraindications. So the mother contraindications are APH, uterine scar due to previous C-section, and the fetal that is CPD and fetal distress. The absolute contraindications are placenta previa and severe fetal compromise. The relative contraindications are breech presentation, transverse lie, cord prolapse, and polyhydramnios. So we have discussed the topic, the induction of labor, and the indications for the induction of labor, which are obstructed and medical indications. Then we discuss the contraindications, which are the mother, the fetal, and the absolute. Now coming towards the next topic, that is Bishop's score. So for Bishop's score, we are having a scenario that what is Bishop's scoring, and briefly discuss different methods of induction of labor. So the Bishop's score. Assessment of the prolonged labor before induction, and fetus size is less than 4.2 kg, and okay, Bishop's score predicts favorability of the cervix dilatation for induction of the labor. The score is greater than 8, it indicates the favorable cervix, and if it less than 8, then it indicates the unfavorable cervix. This is the score, which is 0, 1, 2, and 3. The dilatation of the cervix in centimeter is 0, then 1 or 2, then 3 or 4, then 5 or more. The length of the cervical canal is greater than 2, then 2 to 1, 1 to 0.5, and less than 0.5. Then position of the cervix, which is posterior, central position, and anterior position. Then the station of the presenting part, which is -3, -2, and 1 or 0 or below the spine. Then the consistency of the cervix, which is firm and medium and soft. Now station. Station refers to the degree of the descent of the fetal presenting part through birth canal, and it is -3, -2, -1 or above, and the 0 is at ischial, or it is +1, +2, or +3, and this is below. So this is the Bishop's score. We are having the assessment of prolonged labor before induction, and the fetus size is less than 4.2 kg, and the greater than 8 indicates favorable cervix, and less than 8 indicates unfavorable cervix. So the dilatation of the cervix in centimeter, the length of cervical canal, the position of the cervix, the selection of presenting part, and the consistency of the cervix. This is the station. Now the next topic is the methods of induction of labor. So we are having these are pharmacological methods. For the induction of labor, we are having the pharmacological methods, then the surgical methods, then the mechanical methods. So the pharmacological methods are prostaglandins and oxytocin, that is PGE2, and the surgical methods are artificial rupture of membrane and amniotomy. The mechanical methods are sweep and stretch and Foley's catheter. So the pharmacological methods contain the prostaglandin methods, the oxytocin infusion method, and then we will discuss the complications. These are the pharmacological methods. Prostaglandin PGE2. The prostaglandin cause cervical ripening. They are given intravaginally into posterior fornix. It increases vaginal delivery rate, that is 3 mg tablet, and unfavorable cervix requires 1 to 3 doses of the vaginal PGE2. Then oxytocin infusion. Its action is to increase the cervical prostaglandin level. It acts on myometrium due to increased receptors, more uterine contractions. Infusion should be started slowly on low dose, and it is 4 to 10 per minute and increase every 30 minutes to achieve the optimal contractions, that is through 3 to 4 every 10 minutes. And the complications are C-section due to failed induction, cord prolapse, prematurity, atonic postpartum hemorrhage, and the rupture of the uterus. Then the intrauterine infection with prolonged induction. The side effects of the pharmacological agents are pain, uterine rupture, uterine hyperstimulation, fetal distress, and laceration of the cervix. Okay, so this was the pharmacological method for the induction of labor. Now coming towards the surgical method for the induction of method, we are having the amniotomy, that is the artificial rupture of the membrane. And artificial rupture of membrane is more effective if used in combination with oxytocin. It shortens the interval from induction to delivery by 1 to 3 hours, and it is contraindicated to it includes HIV, active perennial herpes infection, and viral hepatitis. Then we are having the mechanical methods for the induction of labor, which are sweep and stretch. It describes the insertion of a gloved finger through the cervix and its rotation against the wall of the uterus. This safe technique strips off the chorionic membrane from the underlying decidua and releases natural PGs. This method is only possible if the cervix is beginning to dilate and efface. It can be performed more than once. This method is usually performed at term, and placenta previa must be excluded before it's offered. Foley's catheter is used. It is inserted through the cervical canal and balloon inflated. The complications of method are mechanical method are maternal complications and fetal complications. The maternal complications are failure of induction, that is no Bishop score, abnormal uterine stimulation, that is hyper due to overdose of the hypersecretion, leading to tetanic contractions of uterus causing the rupture of uterus and the laceration of the cervix. Amniotic fluid embolism, PPH, and intrauterine infection. These are the mechanical complications. The fecal complications are due to hyperstimulation of the uterus, fetal hypoxia, fetal distress, fetal demise, cord prolapse, and prematurity. So up till now we have discussed the different mechanisms for the induction of labor. Okay, these are the methods. These are pharmacological, surgical, and the mechanical. We have discussed each one by one. The pharmacological methods are prostaglandin, oxytocin, and then we have discussed the complications and the side effects. Then we have discussed the surgical method, the amniotomy. Then we discussed the mechanical methods, the sweep and stretch method. and the Follis catheter and the complications of mechanical method, which are maternal complications and fetal complications. In the next video, we will discuss the fetal emergencies, that is cord prolapse and then the shoulder dystocia. Thanks for watching.